Hi, my name's Nick Smallwood and I'm a consultant in acute medicine. In this video, we're going to take you through the theoretical aspects of the 3-point rule-in DVT module as part of the FAMUS curriculum. We're going to talk about a 3-point rule-in DVT approach. The first thing to cover is the background behind why we think this is important. I'm then going to briefly touch on some of the evidence, including the limitations that it brings, and finally take you through the system of examination with some examples of pathology. Swollen legs and query DVTs are a common presentation to both the emergency department and acute medical unit, and they're a condition where the positive diagnosis will influence your management early. This is particularly in the case of, for example, patients who come in with pulmonary embolism, where if you can identify DVT early, you'll be able to change their pathway quickly. And finally, it's something that AMU clinicians asked for when we started out the process of determining what would be a useful part of the FAMUS curriculum. Now, it's important to say that the technique I'm going to talk about is not equivalent to a rule-out scan. So this will allow you to confidently rule in DVT, but it is not the same as a departmental scan for the purposes of NICE scanning. So some of the evidence. The seminal paper really was this one, which was published in 2000 and highlighted the ability of ED clinicians to scan for DVTs relative to vascular technicians. And they used a policy where 5 ED physicians who were competent in ultrasound but hadn't scanned for DVTs before had an afternoon of teaching, and they then compared their ability to make a diagnosis compared to the vascular laboratory. And the summary statement was that the kappa was 0.9 and there was a 98% agreement between emergency physicians and the vascular laboratory. And this was the first of a number of papers which showed that emergency department clinicians can quickly and confidently learn these skills. The second paper to touch on is this from 2014, which showed that scanning the common femoral vein and the popliteal vein in isolation would miss approximately 6.3% of DVTs. That is to say, around 6 to 7% of thrombosis is found in the mid portion of the thigh in the superficial femoral vein. That's part of the reason why we chose a 3-point rule-in scan as opposed to a 2-point scan. So the limitations I've touched on, but DVT ultrasound in its entirety can comprise B mode to compress the vein, spectral Doppler to determine the direction of flow and look for abnormal flow patterns, and occasionally color Doppler to detect thrombus as an A to B mode imaging. We here are only going to talk about B mode imaging to compress the vein, which is why we can't call this a rule-out procedure. But we do, however, show good sensitivity for the detection of DVT. We're going to be using a linear probe, which is high frequency and therefore has good resolution. In some patients, particularly with a high BMI, you may need to use the curvilinear probe, which has a lower frequency, but will allow you to see deeper vessels. The anatomy to go over of the lower leg is shown here. The 3 veins that we are really interested in are the common femoral vein, and in particular where it meets the great saphenous vein at the saphenofemoral junction. The femoral vein as it passes through the thigh. This is sometimes called the superficial femoral vein, which can cause difficulties with nomenclature. And then the popliteal vein as it passes through the popliteal fossa at the back of the knee. You'll want to position your patient so you can see from between the groin and the knee. We tend to have them supine, so lying on their back. Ideally the head tilted a little because it encourages leg vein distension, and the hip a little rotated with the knee slightly flexed. You can scan the patient with their leg over the end of the bed, which encourages venous distension, but it does require a mobile patient. And as I've touched on, we're going to be performing a 3-point scan: the common femoral vein, the superficial femoral vein or femoral vein, and the popliteal vein. So the first thing to do is to find the Mickey Mouse sign. And on this example of the left leg, that will be where the great saphenous vein drains into the common femoral vein, and also you can see the common femoral artery. This is a well-described sign and represents the saphenofemoral junction. So again, to review those landmarks, we've got the left ear in this case made up of the long or great saphenous vein, the right ear made of the common femoral artery, and then Mickey Mouse's face made up of the common femoral vein. This highlights the proximal part of your scan, and once you highlight this, you will then start scanning by compression of the vessel. You will see on this example image that you've got an early branching of the femoral artery visible here, which is a common variant found. So zone 1 is scanning the common femoral vein just distal to the saphenofemoral junction, and you apply pressure and look for complete apposition of both walls of the vein as visible here. So this would represent a normal zone 1 scan. And if we compare that to the image seen here, which is now on a left leg, you can see a large area of thrombus within the common femoral vein extending up into the great saphenous vein, and there's really no compression required here. Once you've scanned the common femoral vein, we encourage you to track the vein down as it passes through the thigh and becomes the superficial femoral vein, and we recommend every couple of centimeters compressing the vein. In practice, though, all you need to do is place the probe in the mid-thigh and find the femoral vein and femoral artery, and that will give you an image similar to this. Again, you expect both walls to be entirely compressible, which would suggest that there's no thrombus within it. Whereas in this next image, you can clearly see that there's thrombus within the femoral vein, just below the femoral artery, and any attempt at compression will result in no movement of the vein at all. This would be positive for a DVT. The third zone to scan is in the popliteal fossa, trying to identify the popliteal vein. And we ask that you try and find the trifurcation, where it becomes the anterior and posterior tibial veins and the perineal vein. And this allows you to scan proximal to that to make sure we're talking about the above knee DVT. And here an example of how that looks in real life. So we can see the femoral artery at the bottom and the trifurcation of the vein above it. Now in practical terms, you often won't see the trifurcation at the same level. You will see one branch come off, and then a centimetre or two above or below, you'll see the second branch. But it's important to try and highlight all three branches so you know that above that is the popliteal vein. And then you may come across images like this, in which it's easy to see the thrombus within the popliteal vein. And again, there's no compression possible. The popliteal artery below you can see remains pulsatile through the compression, and this again would be positive for a DVT. And so to summarise, we've gone through a 3-point rule-in DVT scan. Zone 1 is to find the common femoral vein or the saphenofemoral junction, the Mickey Mouse sign, and compress. We then recommend every couple of centimetres down, you scan and compress the vein to ensure patency until you get to the mid-thigh, which is zone 2. Here you compress the femoral vein, and again, try and track the vein down until it dives in behind the popliteal fossa. Finally, zone 3 is in the popliteal fossa, just above the trifurcation, where you compress to ensure complete apposition of the vessel walls. If at any point you find a non-compressible vein, then it is strongly suggestive of a DVT, and we would consider that to be a positive scan. The next video in this series takes you through the practical aspects of DVT scanning.